Good morning, good afternoon, good evening, depending on which part of the world that you are tuning in from. It is my great pleasure to welcome all of you to the fourth annual Women Leaders in Global Health Conference. It is an honor to be the host of the proceedings today to talk about something that is extremely precious to me, and I know extremely precious to the thousands of you who have tuned in, men and women both, for this extremely critical conversation at the intersection of gender and health. Now, remember, this is just the beginning. This is going to be 3 days of shining a light on subjects that need to be much more spoken of, get much more attention than they do. Today's focus is on Asia. Tomorrow, the focus will be on Africa. And then on the third and the final day, our attention will be on treating the world as a stage. Let me start by telling all of you a little bit about myself. For those of you who don't know me, my name is Barkha Dutt. I'm a journalist. I've been a broadcast journalist and a visual storyteller for over 20 years. It's getting to be about 25 years now. Most recently, I spent about 120 days traveling across India from the north to the south, covering about 24,000 kilometers, reporting on the COVID-19 pandemic from the ground in a small team of 4 people. And it really gave me a first-hand experience of how women in particular are the soldiers at the front line of this battle. Yet, as we all know, like in all other spaces, this space too remains an extremely unequal one. And the barriers here, the inequities here, even during this health crisis, are ones that don't get enough of our attention. We know Melinda Gates made the point that the pandemic may be gender blind, but it's not gender neutral. And I think all of you who have spent some time in the healthcare space already know this, but perhaps the larger audience doesn't. What we're really talking about now, and even in peacetime, is a healthcare system that is delivered by women, but led by men. The World Health Organization and Women Lift have a report that if you haven't read, I really do recommend that you do. When I went through it, I was absolutely staggered with some of the figures. 24 million, for example, of 28.5 million nurses globally are women. But more often than not just do they not get equal pay, oftentimes they don't get paid at all. We already know that 70% of the healthcare workforce is made up by women, but only 25% of leadership positions are actually taken by women. There are other statistics too, which I'll share with you in a moment. But when I was traveling across India reporting on this pandemic, I came across so many women who represented both the grit and the determination that our gender brings to our jobs, in this case, healthcare, but also how unrecognized, how unsung, how undervalued they are. I remember in the city of Bombay, or Mumbai as we call it, in a public health hospital, meeting a nurse who first had a conversation with me that no one had even bothered to have. The PPE kits, are they designed for women? She was bleeding. She was on her period while she was serving. Very gritty woman. She, in fact, when Mumbai came under a terror siege, the 26/11 terror attacks, as they're called, she was on duty at the same hospital that night too as terrorists stormed the hospital. So she is one tough nut. But she spoke about how being covered in this sheath of plastic from head to toe, having her period while she was attending to COVID-positive patients, actually left her almost asphyxiated. And I'd had the same experience in a PPE while being on my period. And it was something so small, and yet it was a conversation that nobody had even bothered to have. I spent some time in the slum tenements of Bombay, where I met pregnant women who had no access to hospitals because your hospitals were completely overburdened with COVID patients. And at the same time, like many parts of the world, our country too was in a lockdown. And I'm sure many of you have similar experiences that you will share and that we'll be hearing about in your own countries across Asia. And so you had pregnant women who couldn't access, any kind of healthcare services. And you had brave women doctors looking to provide them the service either by physically going into these slum tenements or by setting up what we call virtual OPDs, telemedicine. And we'll talk a little bit about that in a fireside chat as well today. Again, unrecognized, almost uncommented on. And I remember one of the women doctors at the front line telling me that every day I help deliver a baby. I have no luxury of social distancing, and it's all very tactile, and I have to be really close to the patient, and it's like Russian roulette. You don't know if you're going to get a baby or not. And in India, and I was and ASHA workers are accredited women health workers at the front line. Guess how much they're paid? They're actually paid 4,000 rupees a month, which translates into roughly about what, $55 a month. And because they are slotted as volunteers, they don't even get recognized. 1 million women, the first responders during COVID, the people who went from door to door teaching people how to wear masks, how to do social distancing, these remain some of our most undervalued and often underpaid healthcare workers. So 1 million of them. And let me share another statistic with you that really shocked me. Women in the health sector earn an average of 28%, 28% less than men. But they contribute 5%. Women in healthcare contribute 5% to the global GDP, though 50% of this amount remains unrecognized and unpaid. Now, data doesn't lie. And I think if you marry our anecdotal experiences, and all of us have some with these statistics, the picture it really paints is a grim and all too familiar one. Many times we have romanticized the caregiving dimension of women. In our homes, in the Indian subcontinent, in South Asia, it often means that if there's one roti on the table, then that roti, that piece of bread, will go to the children first or to the spouse first, and the woman will often eat at the very end. I have met healthcare workers who have not had enough money to put food on the table in the period of this lockdown. And the women healthcare workers among them have insisted that their families be fed before they are. So whether it's at the very sort of bottom rung of women at the front line or in the top leadership positions, the disparity is there for everybody to see. Like we've been saying, the leadership positions continue to be dominated by men, whereas the bulk of the troops are made up of women. Why does this happen? Is this the same sort of inequity that we see in any other space? I would say there's something about this space that actually makes it a little bit different. We are still discouraging enough women from choosing science and medicine as career options. When we talk to our two brilliant guests in a couple of minutes from now, you will hear their personal stories. You've seen their public avatars as women leaders in their own spaces. But how many women are really encouraged? How many, hand on heart, are really encouraged to take up science as a career? I remember Kiran Shaw, who leads one of the most successful pharmaceutical companies in India, once telling me that in India, in particular, women are encouraged to get a science degree, but then do nothing with it. And that is the other point, that the impediments to career growth, the lack of access to what we now take as minimum basic givens, paid maternity leave or paid family leave, if you will, the fact that women continue to carry the burden of also looking after the home, all of this creates the kind of barriers that need a lot more global attention than have got. And I always like to say, as a proud feminist, that we focus so much on equality at work that we forget to talk about equality at home. Whereas most women that I meet, and I have met many brilliant, brave, courageous women in the last few months of being at the front line of reporting this COVID pandemic, have told me the same thing, that they're actually wielding 3 jobs at the same time. If they're parents, looking after their children, if they're home, if the responsibility of the home is on them, then that, and also pursuing their passion. For women, this tag that we've created of making them into superwomen, I sometimes call it chains of gold. We have used these chains of gold to shackle our women. I hope over the next 3 days, we are able to have some very, very honest conversations of the price that women pay at multiple levels to reach where they do. I say that women have to work twice as hard to get to the same point as men, but I think I might be understating that twice. So think of these figures as we introduce the next sort of our guest today, our first set of guests. As I said, brilliant thought leaders and achievers in their own right. But the fact of the matter is that 70% of the healthcare force globally is made up of women, whereas only 25% are in leadership positions. And women cumulatively contributing 5% of the global GDP, with 50% of their contribution remaining unrecognized and unpaid. That is one hell of a staggering statistic. And perhaps my cue to now introduce our guests today. Let me welcome to the program Dr. Soumya Swaminathan, the Chief Scientist of the World Health Organization, as well as Dr. Sara Saeed Khurram, the co-founder and CEO of Sehat Kahani. Dr. Soumya is from India originally, and Dr. Sara is from Pakistan. Welcome both. I was depressed looking at these statistics, so I'm really counting on both of you to cheer me up, because I think you represent what women can do. But I know that it couldn't have been easy to get to where you have, and I want to spend a little bit of time talking about that. We will talk about the pandemic, we will talk about the vaccine, but we're really here to get to know you both better and also to understand what it takes to be who you are. So, Soumya, if I may start with you as the Chief Scientist of the World Health Organization. You had the advantage of growing up as the daughter of someone who was science-minded. Your father was the man we know as the father of the Green Revolution in India, Dr. M.S. Swaminathan. But even so, when you first expressed an interest in medicine, were you always encouraged, or did you have to cross many hurdles? Did you have to convince a lot of people to allow you to pursue a career in medicine?
Thank you, Barkha, and good to see you again. Was following your travels across India and your stories. And greetings to the audience. Yes, I think I was very fortunate in that as a child growing up, I grew up in a research institute in a campus that was doing agricultural research. My father was a scientist, and so the house was always full of students coming to discuss their master's or PhD thesis, and then staying on as my mother would often feed them. And we would celebrate all festivals, all religions. And so it was a very secular, cosmopolitan, broad upbringing with a lot of exposure to also scientists who were coming to visit my father from different parts of the world. I'm sure that had a big influence. Also, our exposure to the research laboratory. So we would often go with him on weekends to see the animal facility, to go to the fields where the actual experiments were being done of these new varieties of wheat and rice. But at the same time, my mother, who was an educationist, as you mentioned, and a very innovative person, started focusing on preschool education long before anyone had thought that the preschool child was important in shaping the child and the adult. And she was experimenting with learning by doing and different models of preschool education. And one of the initiatives that she was involved in setting up was the mobile creches, which was creches for the children of construction workers. And as you know, a lot of construction workers in India, and I think in other countries as well, are women, and they have nowhere to leave their children, who are often left with an older sibling or who may be 5 or 6 years old, or kept nearby. Sometimes there's no shade even to keep the baby, and then feed the baby intermittently. So mobile creches was set up, to provide care to these young children of construction workers. And so I had exposure to not only, science and research and academics, but we traveled a lot. We went to villages. We met people from different cultures and backgrounds. And I think that did a lot, to shape my view of the world and what I think ultimately became my priorities in life. School also plays a very important role. So I think this is important to understand, that we are all shaped, by the influences when we were children. And that's probably where my interest in science and research began. I can't identify at what age, but it wasn't that I wanted to be a doctor ever. I wanted to be a scientist, a basic scientist. Actually, I took zoology honors in college. And at one point in time, I wanted to be a veterinarian. But again, I think it was just like peer, not pressure, but what my peers were doing was applying for medical schools. I ended up actually going to medical school, but continued with my passion and research, which was something that very, very few doctors really wanted to take as a career. So again, that was a atypical choice for me. Many people questioned that whether it was a wise decision or not, but that's how I started my career in research. I had excellent mentors along the way.
Right. When do you, I agree with everything you've said, that mentors, parents, school, college, these are all very critical influences. But when do you first remember being patronized for being a woman in science, for being discriminated against? The discrimination, as I said, sometimes is not overt. It often comes in this sort of patronizing, talking down attitude. Do you have a memory of when that first happened to you?
I think that happened much later, actually. So I was lucky, perhaps, that during my school and college days, or even right through education, when I was doing my MD, I never ever felt that I was being discriminated against or treated differently as a girl or as a woman. And perhaps that's very unusual. But it was only after I started my career in a government research institution that I experienced this the culture of a male-dominated room, a committee room, male-dominated. Yes, most of our committees were, and I think continue to be, male-dominated. And that's where you felt that you were being talked down to or made fun of almost sometimes. And then you just become very diffident about expressing your opinion next time because you've been either laughed at or shouted down the first time. That, I think, continues today. I do see young women today also being treated differently from a young male scientist, and particularly in these kind of boardrooms when you're trying to defend your idea. Could be a grant proposal, or it could be a new idea that you want to study. So I think that's the first time. I was in my early 30s, perhaps, at that time.
And how did you respond?
Well, I'm not an aggressive person by nature. So I think I tended to be, in fact, cowed down a little bit and maybe inhibited from speaking up the next time. And I remember when my director and one of my mentors, actually, he's the one who really encouraged me, asked me to go and attend a meeting in Delhi. I said, it's pointless. Why do you want to send me? No one's going to listen to me because all the people around the table think they know better. They're much older, they are men, And he said, no, but you're the technical expert and you need to be out there and they will grow to respect you and listen to you, but you have to make a beginning somewhere. So I had a very strong support from him, and he made sure that I kept going to Delhi. I was based in Chennai in those days, and attending these meetings, completely male dominated. Even when I became the DG ICMR, I often felt very awkward because all the people around the room were older men. And then here I was chairing the meeting and trying to bring some order and sometimes telling them, to behave themselves and contribute to the meeting. So it was very difficult for me. I think I learned over a period of time, but I must say that there were a few role models that I could look up to.
Yeah. Also, I found it interesting that you said, I'm not aggressive. The thing is that if you are aggressive, and I think I would self-identify as an aggressive woman quite happily, the way you're judged is quite different from how a man with the same personality is. That's as true for science and medicine as it is for media or any other profession. Thank you for that, Soumya. I have lots more to ask you, but I want to bring in Sara. Sara runs something I referred to in my opening remarks in the Indian context, but just as true in the Pakistani context. How do you get medicine to women who sometimes can't physically go to a hospital or to a care facility? Telemedicine, remote medicine became all the more critical during COVID when as I was mentioning, everything was shut down. But Sara, I read something about you and I was really struck by it, and it fitted in very much with the Indian experience as well. The entire concept of doctor brides. I think you said somewhere that your idea to create Sehat Kahani was born from this reality of South Asia, where women are encouraged to get degrees, but often sometimes so that it looks good on their marriage resume rather than it looking good on their career resume. So, can you speak a little bit about how the notion of doctor brides gave birth to Sehat Kahani?
Sure. Thank you, Barkha. It's a pleasure to be here. And it was great to hear the earlier speaker as well. So I've born into a middle-class family in Pakistan. And when you're born into a middle-class family in Pakistan, if you're a daughter, especially if you have other siblings as well, the most favorite career for parents for their daughters to have, who have money for their daughter's education, is being a doctor in Pakistan. And that's majorly because if you're a doctor, if you're tall, if you're pretty, you become the most eligible girl in town to marry the best bachelor. And I saw it when I went into medical college myself, because my father really wanted me to become a doctor. And when I went into the medical college, I saw that 90% of my class was made up of female doctors, and that continued throughout my medical college when new batches came in. But I saw a very interesting transition that all the girls who were topping their class in the early years of medical college started getting married and having children in the final years. And somehow that small category of men, the 10% of the class, became much more important than the women, because they were actually staying on and practicing with no other priorities. And that exposed me to a very interesting thing in Pakistan, that while majority, almost 70% of our medical workforce is made up of female doctors, only 23% of that ever goes into practice, because the rest of them become doctor brides, or in Urdu we call them doctor bahus, who are married into families who want to bring in a female doctor just so that they have a higher social stature in society. They can show off that bride, but they don't let her work, because working is still considered to be a taboo in many circles in Pakistan. And I also at some time became a doctor bride. And there was a time in my life where I had my child and I couldn't work because I was living in a new city with my husband. And that led me to an ultimate realization that I too have become this doctor bride who can't work. And the only thing that saved me at that time was seeing patients on call in a clinic that I used to head previously in another city. And that's where we did the pilot, that if I, sitting at home in one city, can provide consultations to patients who live in another city, why can't we make use of so many female doctors sitting at home today? There are around 80 to 90,000 female doctors just in Pakistan alone who do not practice medicine after graduation and suffer mentally and emotionally throughout their life by not being able to exercise the degree that they were a part of, and they struggled for 16, 17 years of your life. So if I, a female doctor at home, can provide consultations to patients in another community, why can't all female doctors do that? And another thing that struck me was the Pakistan's healthcare system in the peripheries, in the rural communities, is not actually run by doctors. It's run by a string of healthcare workers, healthcare providers, lady health workers, we call them community midwives and midwives, who were created throughout the history of Pakistani healthcare system to fill the void for female doctors not being able to reach the communities. And these nurses work in communities as de facto doctors, but sometimes they enter into quackery because there is no female doctor to help them. So what we started was, we started making telemedicine clinics in low-income communities where patients came to nurses who were already working there since the last 6 and 7 years. And we trained that nurse on a software by which that nurse can take the history and examination of the patient and then connect that patient to the online doctor. And we had another female mobilizer in the clinic who used to do health education promotion of women coming into the clinic, so that they knew what their conditions were and they can then talk to a doctor. But when I started my first clinic around 4 years back, I think everyone that I told this to, that a female doctor sitting at home through a nurse is going to provide consultation in a low-income community to majorly women, people laughed at my face. People said, this is not possible. It will never work out. But slowly and gradually, we started creating clinics. We have 27 of them now, all across Pakistan. We've served almost 175,000 patients. And we also ventured in making a mobile version of it that everyone can use in Pakistan and connect to female doctors. So from one doctor, we are now standing at 1,500 doctors that we've empowered through our company to get back into work. And this is obviously nothing. There's so much to do for these female doctors.
Fantastic. But share something personal. Like I asked Soumya, when was the first time somebody talked down at you? What's the most annoying thing or the most horrible thing you've had to hear as a woman in this space?
So, I am a 33-year-old female entrepreneur in a community where you can handpick female entrepreneurs, especially in the health tech space, which is primarily on a political level, on a bureaucratic level, on a systemic level, is dominated by men. Because as you said, there are more female doctors, but there are so little in leadership positions. So even till date, I think I get questioned. I was giving a training just a few days ago about this new version of the software that we've launched. And a senior doctor asked me, "Have you ever been to a hospital, young lady?" And I was shocked that even after creating this organization, proving so many times again then that technology can help mitigate so many barriers for women, he still asked me that if I was experienced enough, if I had ever been to the hospital. So I have experienced a lot of incidents where I was patronized. I have a for-profit organization, so I also have to raise money. And I have heard this time and again that what and how will you make this amount of money work for your organization? Because you have children, you have family to attend. How will you professionally give so much to the company? How will you take care of the money we're investing in you? I've been asked by an investor to give me a 70% of my company so that he can run it better than me. So I've experienced this time and again in the Pakistani culture a lot. But I think I've also come up because I, on the other hand, am one of your types. I'm also pretty aggressive. So I have managed comebacks, and both silent and aggressive comebacks, to make sure that I'm being heard by the men and the women in the room both.
Good for you. But I'm so glad you brought up women and money, because I want to take that to Soumya. Soumya, if you look at the numbers, women in the health sector earn an average of 28% less than men. 28%, and that's just a documented number. We have no idea how many women are just falling through the cracks, because in many cases, in homes, for example, women are primary caregivers when someone is ill. During COVID, we've seen that again and again. The brunt of economic hardship falls on women. So, have you found it difficult? Because this is the one thing, despite my aggression, I'm not good at, is asking for money. Have you found it difficult to say, pay me more?
So I think that's a great point, Barkha, and something that we need to keep drawing attention, I think, of the policymakers to this fact. The thing is that I've worked in institutions where there was no gender-related pay imbalance. So these are basically government institutions. So I haven't specifically experienced that. But I think it applies to scientists and researchers in that it's more difficult for women to get their grants approved than men, and for everything else being equal. And this has been documented, including by big global research agencies, research funding agencies like the Wellcome Trust, that a significantly smaller proportion of the research grants go to women. Women also have more difficulty in getting their results published. And particularly if you're a woman from a developing country, the publications that you submit to journals are scrutinized that much more and may be rejected on far less grounds, just because reviewers have some perceived biases in their mind about the quality of work that could have been performed by you in a developing country setting. So I have faced those kinds of challenges and barriers, but not directly related to the pay.
Engineering work before you became the chief scientist at the WHO in tuberculosis. When you were doing that, what are the sort of gendered obstacles that you found in your way?
Yes, so I worked for a long time with the Indian Council of Medical Research, starting off as a young researcher at the Tuberculosis Research Center in Chennai, and then eventually becoming the head of the ICMR, the Director General, in 2015. And in between, I spent a few years as director of the institute. For me, my observations started early in my career. I had done some training in the US and the UK. And when I went back and joined a research institute, I found the culture was very different. In that, it wasn't so much the gendered discrimination. It was more to do with being a young person, and perhaps being a young woman put you even one step further down on the ladder. But I was not taken seriously at all. I was always being told what to do. And if I had ideas about something, it would usually be shot down. And I think that's the way some of our institutions function. You know, they're very patriarchal. Still, they were set up. In fact, I remember it's amusing, an amusing incident. But I met the 93-year-old head, one of the people who set up that institute in the 1950s, a very famous British tuberculosis scientist. And I went up to him at a conference, introduced myself as the director of the TRC, and he looked shocked, and he looked at me and said, "What? They've got a woman there now?" So this then reflected, you know, when it was founded in the 50s and then in the 60s, one could imagine that men would not be even able to consider a woman as becoming the head of an institution. But now we're, you know, well into the 21st century. But I think some of the policies that have come down over time actually haven't been changed. And this is where our agencies really need to look at those policies. So a few things really struck me. First is that you mentioned nurses. We had a lot of nurses and health visitors working in our institution, but no one ever asked them what they thought. The doctors, you know, decided everything. The second was the social workers. I learned so much from them, and I believe that social and behavioral sciences is also a science, and people often forget that, especially, you know, if you're in the pure sciences or in biomedical research, you forget the importance of that. And I insisted we create a division of social and behavioral sciences in the institute. And I continued that as I became the head of the ICMR. I tried to strengthen that element of work. Then the attention to the third gender. I mean, we worked a lot with them because of my work in HIV. We worked with the eunuchs and hijras, and I invited them to come and speak to the staff at the institute. And most of them were in tears at the end of it. And they said, we've never, ever heard in first person, because we always treat this group a little bit differently, stigmatize them. So we work with a lot of gay people as well as a lot of transgender and, you know, mixed groups. And that exposure to most staff in the institute was something for the first time that they were actually sitting in the same room and talking. So again, it's a matter of having these opportunities to discuss and understand each other's point of view. So I tried to bring in interdisciplinary approaches to a lot of the scientific questions when I became the head of the ICMR. Again, I did face barriers in terms of the fact that anytime I walked into a meeting, whether it was a meeting of, you know, senior government officials, or whether it was a meeting of advisory committees, it was male dominated, and unfortunately, again, I think it's personality types. If you're relatively quiet, then you're often ignored, and I've seen this happening at the global level as well in meetings where a few vocal people, usually, you know, educated in the West, either born and brought up or educated, tend to dominate meetings, and women from the developing world often have a lot to say but don't have the opportunity to say it. So I think this is something that we have to practice as women in global health. We need to practice being more vocal and being able to assert ourselves when we have a point to make in a meeting. But I think, to me, my experience of working in communities and the fact that we didn't listen to all of these voices. You mentioned, Barkha, that you went and met nurses, and it is so important to listen to them, especially when you're a policymaker sitting in the capital of a country and making policies. If you don't have the right voices, if you don't have civil society, if you don't have the people who are ultimately impacted by the policies, your policies would either go very wrong, or they would never be implemented properly, or they could actually be damaging. So to me, being inclusive is something that I tried to bring in, and it was a challenge because, again, it was trying to break some institutional norms and barriers.
Sorry, I didn't mean to cut you short, but we have just a couple of minutes left, and I just want to bring Sara in on the great paradox of Asia, which is that we are countries that have been led by women well before the West, right? Whether it was an Indira Gandhi in India or a Benazir Bhutto in Pakistan. So we haven't had the Western problem of not accepting women at the very top, but our trickle down in terms of gender equity is extremely skewed. And I'm so glad Soumya spoke about nurses because, like I said, 24 million of 28.5 million nurses globally are women, and who's listening to them, who's talking to them. So, Sara, going forward, do you think there's a generational shift? Do you think your generation, being the youngest person in this conversation, is daring to dream bigger?
I'm an optimistic person, although I haven't seen a lot of change from the generation that my mother belonged to mine. I still see arranged marriages happen. I still see female doctors not working. I still see people coming to someone's house and saying that we'll take this lady into our house, but she can't work after marriage. I still see that. But I do see opportunities in technology, in innovation, which will find answer to these solutions. And I also see that a lot of young women are now standing up and making examples for their daughters to follow. So there are more and more women who are coming into work now, who are staying, who are multitasking, who are making sure their voice is heard. So I'll be optimistic, but there is a long, long way to go. I think particularly in healthcare, a lot of Asia and a lot globally is governed by women in the actual work, nurses, midwives, female doctors. And more respect and more credit needs to be given to those nurses, those female doctors, because all the nurses that I've worked with, they all say that we don't want money. We just want our work to be respected. We just want ourselves to be heard. And we all want dignity in our work.
We're paying our frontline health workers in India $50 a month. That is their base salary. So I think apart from recognition, there is, money should also be paid. But I take your point. I'm sorry, Sara. Did you want to just add a sentence there? I want Soumya to have a quick closing word. Just if you want to add a sentence there, Sara.
So I think for me, there's this force of female workers and these force of female doctors who might not be able to contribute physically. I think there's so much opportunity in using technology and innovation, bringing them into the mix. And the more we do that, the more we're going to empower more women come into the workforce and start working.
Okay. I'm on the clock here, Soumya, but I can't let you go without asking you about COVID. I think the world will want to know how far are we from the vaccine? What does it look like? I know you can't fit that into like 30 seconds, but just give us a quick closing comment as briefly as you can.
That's tough. But yes, I think we are still in the midst of it. We are nowhere near the end of this pandemic, though I must say that we should remain optimistic because we have better tools, we have vaccines coming, we understand the protective measures much better now. We do need to support each other. And I think, as you pointed out, women and girls have been very badly hit by this pandemic. And we need to go make sure that we have those social safety nets in place to protect them and to see them through this period of vulnerability till we get back. So I would say, 12 to 18 months, things should start really, at least beginning to get back to some kind of normality. But till then, life is going to be hard for many people who are less, lucky than us. And so I think solidarity, compassion, empathy, these are very, very important.
Okay, I will have to close on that note. Dr. Soumya Swaminathan, Dr. Sara Saeed Khurram, thank you so much. I hope many women listening in draw inspiration from your story. I think we underestimate the impact that actually our own stories can have on other people. And so we should all be telling and sharing our stories more and more. I'm going to basically now lead you to the next part of this conference. They're going to be smaller groups, a chance to deep dive into issues, what we call the breakout sessions. And we're going to be looking at a range of different issues, from the psychological impact of the COVID crisis on women, to women in the media, to what's happening at the level of community. You just heard Soumya speak about that. What sort of advocacy for change can be built around this moment that we're in, and what leadership in a crisis looks like. Is there a female leadership that is different from male leadership? All very interesting things sort of coming up. So 5 breakout sessions. I hope you enjoy them, really get under the skin of the matter, so to speak. And then I will see you back for the plenary. I hope you enjoyed talking to Soumya and Sara as much as I did.